This is LiveWell Talk on COVID-19. I'm Dr. Dustin Arnold, Chief Medical Officer at Unity Point Health St. Luke's Hospital. Today's podcast, I'll cover the latest on COVID-19, which will include the FDA's decision made several days ago regarding vaccines for children ages 5 to 11. Also, I'll touch on other topics that we commonly discuss. And then we'll have another edition of the mailbag where I answer questions from you, our listeners. What we're seeing in the hospital, we continue to see this persistent plateau of COVID patients. Again, it is consistent that the unvaccinated, about 75% vaccinated, 25%. Then that has been fairly persistent. But there's two things I wanted to bring up today to be encouraged about. And that first is that the rate of transmission for Linn County is down to 0.73, that less than 1. That means cases are decreasing. And additionally, the number of active cases are going down as well. So you have the susceptible bucket, active case bucket, recovered bucket. And so we're having less people, we're having more people exit the active and go into recovered than are entering that bucket from susceptible. So that is a good sign from that standpoint. Flu vaccine clinics are up and running. You can get those at your physician's office, but also the pharmacies, and I know Hy-Vee has it. But the big news this week was the FDA's approval to authorize or amend the emergency use authorization of the Pfizer vaccine for children ages 5 to 11. Now I'm going to walk through this process. So the FDA has their advisory committee, and that committee made a recommendation to amend the emergency use authorization for Pfizer to go down to 5 and 11, children's 5 to 11 years of age. Then the FDA said, yeah, we agree with that, and the FDA endorsed it. The next step is the ACIP will meet, which is the Advisory Committee on Immunization Practices, and it's really that's the one that probably has the most weight with clinicians, their recommendations. And the AICP will recommend to the CDC next week whether or not they agree with that, and then that will be the amendment to the emergency use authorization. Now, sometimes it's confusing because you hear approve and approve and approve. The FDA they're not obligated to accept what the advisory committee says. Neither is the CDC, but that is the steps that do that. So we'll have to see on that. Now, I think vaccinating children, I think I've discussed that with a pediatrician. Kids can be hospitalized, thankfully not very often with COVID-19, but they're also susceptible to, if they get it, they're probably going to do fine, but there has been case reports of the long haul syndrome or this long COVID going out 6 months. That's been well reported in the medical literature. So there might be an advantage to giving the vaccine to the children just from that standpoint. And also, yeah, children will not get extremely ill from it. They'll be coming to believe that vaccinated spreads it just as much as unvaccinated. It really doesn't prevent transmission. But if they're vaccinated and they get exposed, they won't have to quarantine. And so that's an advantage there, just logistically. And I think that should warrant a strong consideration based upon that logistic. I did want to follow up on one question or one comment I made last time. If you get the risk of the messenger RNA myocarditis is greater after the second dose than the first dose with the messenger RNA, which would be Pfizer Moderna. And they believe it's the same rate of risk with the third dose. If you develop myocarditis from the second dose, I don't think you should get the booster. But if you didn't, you have the same risk you had with the second dose in doing that. So it's not a cumulative risk process. Speaking of the Moderna vaccine, they also proved this week that it could match Pfizer in providing a booster shot for those over the age of 65, ages 18 to 64 with medical conditions, and ages 18 to 64 at high risk for exposure because of occupational or institutional setting. They approved that for Moderna, but Moderna is at a half dose, and they're both recommended to be 6 months after the second shot of Pfizer or Moderna. Johnson and Johnson, they also approved a booster or a second shot, and that's anyone over the age of 18, and it is recommended to be at least 2 months from the first J&J shot. I would almost describe the J&J as not a booster, but as a second shot, just based upon the literature that I've been reading. Also this week, noted that the FDA Advisory Committee is going to review the data on the Merck oral antiviral, which will really add a lot to our armamentarium to treat this early and prevent hospitalizations. That's the end of the COVID update, but stick around and we'll be right back with the mailbag. Welcome back to the mailbag. The mailbag is a new segment on the podcast where I'll periodically answer questions submitted by our listeners on medical-related topics, in addition to COVID-19 topics. Our first question comes from Jacinta. What are some therapeutics that could be prescribed early in the symptoms of COVID-19 to prevent hospitalization? Well, that's a great question, and that's been a huge debate. The most used one, the one that we have available to us, is the monoclonal antibody infusion, to be given within 10 days of the start of symptoms to prevent hospitalization. And that appears to be very effective. Once the Merck oral antiviral comes out or receives authorization, that'll be another opportunity. Now, there's been listing in the literature of ivermectin, azithromycin, fluvoxamine, which is an antidepressant, vitamin D. And if you really look at the literature, there's a lot of noise. There is meta-analysis completed that's inconsistent with it being effective. CDC and FDA have recommended against using ivermectin. If a physician and a patient wanted to try that, I wouldn't recommend it, but I would stick with the dose that's normal for ivermectin and not dose it to exceed its recommended dosing for sure. Hydroxychloroquine was also mentioned early on in the pandemic, and those are things that really don't have the evidence to support their standardized use for all patients. So at this time, we're really limited to the monoclonal antibody that is effective and also can be delivered subcutaneously, so you don't have to sit through an IV infusion, and the antiviral that will hopefully come out late in November. The second question is from Tina. Why does medical guidance, mask guidance, or cancer screening guidance change so often? And what do you think is the best source to keep up with these changes? Well, they change because science is not ever settled. Science is the pursuit of the truth, and you continue to keep trying to discover that. And so they do look at guidance for colon cancer screening that was recently adjusted, and over time it will probably be adjusted again. The mask guidance, the difficult thing with the mask guidance is that there's no solid evidence, meaning a randomized, controlled, double-blinded, placebo-controlled trial of wearing a mask or not wearing a mask, and then the outcomes. There's observational evidence that it may help. You can find observational evidence that says it doesn't help, but it doesn't hurt, and it may work quite well for droplet or source control. I do think that the best place to look for guidance is the Center for Disease Control. They've been consistent with that. That it's interesting that this question is asked because as a medical staff, at the beginning of the pandemic, we were mixing World Health Organization with CDC, and it was very confusing. And so, because the CDC would be inconsistent on one compared to the World Health Organization, and so as a medical staff, we follow the CDC guidelines and then take it from there. Next question from Sarah, which actually came up last week. What's your opinion on mixing brands for your COVID-19 booster? It's an unpeer-reviewed study, but it does state that you can mix and match, if you will. Personally, I received a booster being in healthcare with Moderna, and my first shots were Pfizer. And that was because that's what was available. The additive benefit appears to be quite significant if you receive the J&J and then you follow that up with a Moderna booster. Pretty significant where they've measured the antibody response, the immune response to be 76 times greater than what would be expected, which I don't know how accurate that number is, but it's certainly of interest, and it is safe to do that. And I think it will help overall people to receive the vaccine because they won't have to try to logistically figure out whether it's Pfizer or Moderna, et cetera. I would continue to avoid the J&J vaccine if you have a history of blood clotting disorder. That I would do. And if you have, if you're a young male, ages 15 to 24, I think was what it is listed, you have a little increased risk of myocarditis, pericarditis with the Moderna and Pfizer. So those are two things that would probably help steer my decision in taking that. And that's all for the mailbag today. If you'd like to submit a question in the mailbag, go to unitypoint.org/mailbag. I'll answer questions about COVID-19, the latest technologies and procedures, services provided at UnityPoint Health Cedar Rapids, and other medical topics that may present. Please note, however, the mailbag is not an alternative to a medical appointment. Any questions about personal symptoms or conditions need to be directed to your primary care physician or an urgent care if that's the case. In case of emergency, always present to the nearest emergency room or dial 911. Once again, you can submit your question to me at unitypoint.org/mailbag. That's unitypoint.org/mailbag, MAILBAG. I look forward to hearing from you, our amazing listeners. Thank you for listening to this COVID-19 update. For the latest COVID-19 vaccine information and more, visit unitypoint.org.
Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe. And if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.